Welcome everybody to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I have a few housekeeping remarks. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find evaluations by following the link in the chat or at any time on our website and email advertisement. In addition to our usual evaluation, we also have a biannual evaluation today. We ask that you please complete both. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Sultan has disclosed that she has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. It's my great pleasure to introduce our speaker, Dr. Aya Sultan. She is a board-certified physician and researcher. In 2016, she opened Honu Women's Health, a private women's and aesthetics clinic dedicated to helping women achieve inner health and outer beauty. She received her MD from UMDMJ, which is now Rutgers University, and her PhD from the University of Maryland. She completed her residency in OBGYN at the John A. Burns School of Medicine. She has over 20 years of experience in medicine and research, which she utilizes extensively to provide her patients with the most innovative, comprehensive, and personalized care. She has received numerous awards and accolades for her leadership, patient care, and mentorship of aspiring medical students and current and former residents. So please join me in welcoming Dr. Aya Sultan. Dr. Sultan?
Well, thank you for that very kind introduction. I'm happy to come back. I think this is my third time now with you guys and talking in terms of geriatric gynecology. Per request, this lecture is going to be about urinary incontinence, which I think is a very timely and important subject. So unlike this picture shows, we're going to be focusing on urinary incontinence in women alone. So men is a whole different story, and I leave it to someone else. All right, as mentioned, I have no financial disclosures. So learning objectives. So upon completion of this presentation, you should be able to understand basic types of urinary incontinence in women with a specific focus really on the older woman. You should be able to identify and diagnose the common causes of urinary incontinence and offer different treatment recommendations for the different types of UI. Just as important as to treatment recommendations is knowing when to refer the older woman.
Dr. Sultan?
Yes.
I'm so sorry, I just wanted to interrupt for a minute. We don't see your slides yet.
Oy, and here I went. Okay, let me do it again. I'm glad I saw your fingers.
Thank you.
Do you see it now?
No, not yet.
Oh, hang on. We did test this out.
Yeah, there it's coming now. Yes, it's on now. Thank you.
No problem. All right, let's start this over again. So again, welcome everyone and thanks for the introduction. Basically today it is going to be about urinary incontinence in women, and so just wanted to kind of give you that thought. Men will be a different discussion by a different provider. No financial disclosures. As I stated, basic types of urinary incontinence are going to be discussed, especially as it relates to the older woman, being able to identify, diagnose, and offer treatment recommendations for the common causes of urinary incontinence in the older woman, as well as offer different treatment recommendations and knowing when to refer. So this is a very apropos slide, basically, that covers the different types of incontinence that we're really going to go into, which is basically whenever I sneeze, I pee, and that is the stress incontinence. Whenever I laugh, I pee, still stress incontinence. And then you have the gentleman, which could also have been the third lady, saying, well, let's see if I can get to the restroom without peeing on the way, which is basically our urgency or a type of incontinence. All right, so what is the scope of the problem? Why is it so important to discuss this, especially in our elderly female population? The answer is threefold. Basically, it is a myth that it is normal to start having small bladder leaks as women get older. Incontinence is a natural part of aging is also another myth. The fact is our bodies are not naturally designed to just start leaking at a certain age. And so while urinary incontinence is common as we get older, it's never ever normal. So it should be addressed. It is one of those things, however, that nobody really wants to talk about it. People are uncomfortable, embarrassed to mention it to their physician or other PCP. It's one of the most common medical conditions among older people. And according to the CDC, it affects more than half of women age 65 and older. And up to 80% of long-term care residents will have this condition. Older adults have a hard time if they have urinary incontinence. It impacts the quality of life, risk of depression increases, too many become socially isolated for fear of having incontinence during different types of events. Risk of disabling falls increases, and it's associated with a loss of independence and ultimately institutionalization. And unfortunately and sadly, it is underreported and undertreated. Compound this to the fact that this is basically what's being put out there, and it is the fact. We have only about 18 seconds, apparently, to talk to a patient before we start interrupting them and wanting to get to the focus of their visit. So, due to the fact that it's so underreported, providers are starting to be encouraged to speak with patients and basically try the some people approach. When some people cough or sneeze, they leak urine. Have you had this problem? But just as much as providers are being encouraged to speak with patients, patients are being encouraged to speak with their doctors. So basically the National Institutes on Aging have been very good in terms of getting out there this information and saying, if you have trouble controlling your bladder, it's important to let the doctor know. And even just putting up signs in the office that the NIA has released in terms of information for patients can be a gateway to a discussion. So the basics. What is urinary incontinence? Well, by definition, it's just the involuntary leakage of urine. Its incidence does increase with age, with postmenopausal women having about 75% report of urinary incontinence or UI. It is the reason for admission to nursing homes in about 6% of older women. Its prevalence, as I just said, increases with age, but also with obesity and disability. The economic burden is huge. For urgency UI, the estimated total national cost of urgency in 2007 was about $65.9 billion, and with an estimated cost of about $82.6 billion in 2020. If you look at the graph on the right, you can see in terms of relation of other medical comorbidities that we talk about with patients, and osteoporosis and arthritis are really given a lot of discussion with our elderly patients, but just as common and maybe even more so is urinary incontinence in our elderly folks. For stress UI, we're looking at least a $12 billion spent annually, and there's a lot of out-of-pocket costs for patients, especially with 70% of conservative management being our discussion points. When we talk about direct costs in the table to the right, you can see that includes both diagnostic costs, treatment costs, routine care, consequence. So basically treatment for falls, treatment for infections, etc. So again, urinary incontinence results in a wide range of urinary systems that can affect both women's physical, psychological, and social well-being, as well as impose those significant lifestyle restrictions. Again, emphasizing the point, many women are hesitant to seek care or discuss symptoms with their physician. Physicians should elicit information from patients and screen for symptoms, and identifying the etiology of each woman's urinary incontinence symptoms and developing an individualized treatment plan is very important for improving quality of life. So how do we go about doing that? Well, first we go by what are the differential diagnoses for causes. So we can talk about the genitourinary causes as well as the non-genital urinary. And we talk about filling or storage disorders, fistula formation, infections. If there's a congenital abnormality, is it functional as in neurologic, environmental, pharmacological, metabolic. So a very nice little mnemonic that has come out and been sent out to people to just keep in mind is diapers. So looking in terms of delirium, which is part of the functional category, infection or irritants, atrophic vaginitis or urethritis, pharmaceuticals, and under pharmaceuticals, which would include medications, would be things like just even, fluid intake of alcohol, smoking, etc. Psychologic depression or dementia, endocrine disorders such as diabetes or hypercalcemia, if they have restricted mobility or even stool impactions. So this kind of covers very nicely what are the different causes that we should be looking for in terms of urinary incontinence. All right, main types of urinary incontinence are stress, urgency, mixed, which would be a combination of stress and urgency. There is also the overflow and the functional incontinence, which you can see on the right as described as neurogenic incontinence. There are other subtypes, and basically they're not going to be discussed during this lecture. We're going to focus on the main types. And if you look down at the figure, you can see the prevalence of the main types, with urgency being the largest type or the more prevalent type as we progress in age and overall. Mixed incontinence being second, and then followed by stress incontinence. All right, so where does evaluation start? It starts with a thorough history, a thorough physical exam, assessment of the symptom severity. The important factor here is rule out reversible causes and address if present. There are a lot of different causes of urinary incontinence besides the typical ones that we would address. And so it's important to rule out those, especially if incontinence is a new onset symptom. And then discuss with patients their goals for treatment. So this starts with a focused history. So there's a lot of factors that we would need to address in terms of onset and duration, the severity, symptoms and their progression, what is their fluid intake, what are potential bladder irritants, what are the medications that they're on, have they been previously diagnosed or treated, and then thoughts on in terms of what is the type of urinary incontinence. So within this presentation are a lot of nice slides. I've given figures, I should say. I've given the references at the end that you can find, but there are a number of reviews that have come out over the past few years to address urinary incontinence, and I encourage everyone to at least read it. This is a compilation of these reviews. All right, so again, we went through in terms of a lot of these factors assessed during the medical history. One of the things that can make our timing, if you will, shortened in terms of asking patient questions in terms of incontinence is these validated urinary incontinence questionnaires. There's a number of them out there, such as the UDI, the IIQ, the QUID, the IQOL, the ISI, and the ISIC. And these can help facilitate the discussion as well as the diagnosis. And on the right is one that I actually will use in the clinic, and it is the QUID, with the questionnaire for female urinary incontinence diagnosis. And basically, it's quick and simple, 6 questions, and each one of these points are graded from 0 to 5. And we'll go through in terms of how to score it and what it tells. But the first 3 questions are related to stress incontinence, and then the last 3 are related to urge incontinence. All right, common medications that can cause urinary incontinence. You can see a whole host of these, and they're very common medications that are used, especially in the older population. So you can see the adrenergic agonists and antagonists, the ACE inhibitors, the anticholinergics, calcium channel blockers, diuretics, even things like SSRIs and gabapentin. All right, another way to simplify and potentially improve diagnostic as well as evaluation testing is to have a template like this where it is focused basically on urinary incontinence. And so making sure that we hit all of those points that I just previously discussed with you. On here is also how the physical exam portion and recording should look like. All right, so physical exam, what does that entail? Well, the primary purpose is to exclude confounding or contributing factors to urinary incontinence or its management. So first and foremost is BMI. As we discussed, obesity is one of the most common risk factors for urinary incontinence. There should be a brief psychiatric and neurologic exam and the understanding that urinary incontinence may actually be the presenting symptom for neurologic disease. So part of the screening exam should assess mental status, sensory and motor function of the perineum and both lower extremities, looking at mobility, examining the sacral segments, especially 2 through 4, and examining the anal wink and bulbocavernosus reflexes to assess the integrity of these sacral reflex pathways. It's important to assess the abdomen, including flanks, to ensure there's no CVA tenderness. You're checking for masses, you're checking for a distended bladder even after voiding, and even signs of fluid overload. With regards to the pelvic exam, this will be very detailed. You're going to do a bimanual, including pelvic floor muscle examination with assessment of the muscle strength and voluntary muscle relaxation. So to the right, you can see a diagram discussing pelvic muscle tone and contraction. You're going to assess these motor and sensory differences, examining for any kind of defects as well as asymmetry. You want to examine the organs with an empty bladder. You want to examine the organs for prolapse, such as cystocele, rectoceles. You also want to evaluate for incontinence with a full bladder. So prolapse, please be mindful that it can mask or decrease the severity of a woman's incontinence symptoms, especially if her incontinence is due to stress. So you want to reduce the prolapse, for example, and then ask the woman to cough. And we'll go through the cough stress test in a moment. You're going to also make sure that you rotate the speculum when you're doing this kind of an examination to evaluate both anterior and posterior vaginal walls. So we talk about rotating the speculum on the right. You use a plastic speculum. I'm not sure. Hello?
I think your volume is...
Anyways, you can actually unscrew the speculum and remove this knob, and then you'll have the top blade and the bottom blade. And with the bottom blade, you can insert that by itself and have a very good visualization of the anterior portion of the vaginal wall. You can then lift it up and again have a very good visualization of the posterior aspect of the vaginal wall. So either way, and you don't even have to unscrew it, you can do just the same thing as with a plastic speculum, and that is maneuver bulges, and again helps examine for prolapse. You're going to examine the for any kind of as well as masses, and discharge, which may also confuse the patient for urinary incontinence. All right. And pathology can also and we'll get to that. Examining neural, assessing anal sphincter tone and strain, looking for the prior anal sphincter tears or other rectal pathology. And this is where we truly want to be mindful of rectovaginal fistulas. Again, on the previous exam, looking for any kind of vesicovaginal fistulas, such as from the bladder to, or the urethra to the vagina. All right, so the cough stress test, I alluded to this earlier, and that is basically performing, having the patient, as I said, you're done with the patient, but if no loss of urine is seen, you can repeat it in the standing position. Fill the bladder if you need to. And you want to do it until the patient feels like she needs to pee, or at least a minimum of 300 mils if the patient does not report that sensation. You ask the patient to cough. Basically, a positive test is you see urine loss. Just as a kind of side note, one of the things that was taught to me in residency, you do not want to be in front of the patient while she does this. You want to be to the side just to minimize any exposure to yourself. If there is delay in urine loss for at least 5 to 15 seconds, it is considered a negative test and suggests that the patient may actually have a cough-induced overactive bladder rather than a true stress incontinence bladder. If it is negative, you can, as I said, repeat with retrograde flow. And if symptoms are highly suggestive of SUI, but the stress test is negative, then this is one of those times that you would want to refer for urodynamic testing. Okay, to the right, you can see of cystoceles. In the very first one, there is no cystocele. Then you can start to see the smaller grade 1 cystocele, and then as it progresses, where it fills up pretty much the vaginal vault. All right. Before initiating any treatment, again, you want to confirm that there's no reversible cause. You want to screen for UTIs. There is definitely an association between low colony count and lower urinary tract symptoms. However, mind that elderly patients have a high prevalence of asymptomatic bacteriuria. So you want to interpret these results with caution. So basically relate them to other symptoms to avoid overdose of antibiotics. You also want to determine a post-void residual urine volume. This is going to be very important and part of the evaluation process. Do this by either having ultrasound measurements, or you can, what I like to do sometimes is just straight catheter a patient, collect it in a cup, and this gives me the post-void residual, but it also allows me to check for a UTI in the patient, so it has both options. In terms of catheterization, just be careful. Again, we do know that use of catheterization can increase risk of UTIs in and of itself. Typically for patient comfort, I will use like a PD size catheter, which is basically a 5 French. It doesn't need to be a large, it's a quick in and out, and patients usually tolerate this very well. Now, in normal young patients, i.e. patients less than 65 years of age, the normal post-void residual should be less than 50. However, in patients over the age of 65, normal can be as much as 100 mils, but should not be any greater. If the PVR is elevated, you want to repeat the test on another day. If it is persistently elevated, this is when you want to refer patients for urodynamic testing as well as evaluation for other potential causes of their incontinence. PVRs greater than 400 are likely a symptom of overflow incontinence, for example, chronic urinary retention. And once again, elevated PVR in the absence of any kind of prolapse is uncommon and should trigger referral. So a lot of the times, diagnosis of incontinence can be made with these basic office evaluations, and therapies can be initiated based on these findings. So we come to this point where we've talked about patient complaints of urinary incontinence, or it's been elicited. What are the things that we do? Well, we have a thorough history. We rule out the reversible causes, such as the diapers assessment. We did our UA, we did our stress test, and now we've diagnosed or come to the conclusion of a type of incontinence that we feel comfortable with dealing with. And so let's start with cases. I know that this is where it really hits home. So case one is a 77-year-old woman who comes in with her daughter, who reports, and the daughter reports that the mom keeps complaining to her of loss of urine. Now, you've seen this lady several times, and she has never reported it because she's been embarrassed. Her history is significant for diabetes for the last 10 years. She's been trying to control her diet. She drinks about 4 to 5 sodas a day. She has insomnia and needs to take Tylenol PM. She has frequency and nocturia. She also has constipation, and she has a history of a hysterectomy. On physical exam, she is obese but has no evidence of masses. Her neuro and psych exam were negative. Her pelvic exam shows no evidence of prolapse. She does have hard stool in the vault. Her UA is positive for glucose, but no signs of infection. Her hemoglobin A1C shows that she is not very consistent in terms of diet control, and her PVR is 50 mils. On her intake, her QID screening came back as positive for urge incontinence. So it was very, very easy in terms of determining what type of incontinence this person has. Again, with regards to the QID, there's a score. Each one of these questions is scored 0 through 5. You add them up. The top 3 are responsible for giving us our stress incontinence. If you have a score of 4 or greater, then it's considered positive. For urge, a score of 6 or greater is considered positive. So you can see that they won't have just clear delineation of one or the other. There will always be a little bit of here and a little bit of there. All right. So what are some of the things that we can do in terms of treatment? So we've diagnosed a urge incontinence. The crux of treatment with basically all types of incontinence for the most part is lifestyle modifications. It has been shown that the behavioral therapy, whether it's group or individual instruction, resulted in 50% reduction in mean incontinence episodes, regardless of type of incontinence. In other words, for stress, urgent, or a mixed type of urinary incontinence. So what are we talking about when we're talking about lifestyle modifications? We're talking about diet and fluid management. So restricting irritants like soda. We're talking about timed and prompted voids. So instead of going, 4, 5, 6 hours in terms of not going to the bathroom, going more frequently, maybe every 2 to 3 hours. You also want to emphasize the need for adequate hydration. So one of the problems with incontinence is the fact that patients don't want to leak. And so what causes the leak is urine. What causes urine is they're drinking. So therefore, they're going to drink less. The actuality is you want them to hydrate well so it can prevent things like constipation from hard and stooled. And in fact, you want them instead to do more prompted and timed voids. Weight loss if they're obese. Pelvic floor training and exercise is very helpful as well. Kegels are helpful, but they're only helpful if they are consistent about it. And being consistent means doing this on a daily regimen. Just like daily exercises are recommended, Kegels are recommended daily. If they're not done daily, if they're even done, you know, a couple, 3 times a week, they're not effective, and that's been proven. You can send them for pelvic muscle rehab, which can improve muscle tone. You can even do things like vaginal weight training, and this can be, again, via the pelvic therapists and pelvic therapy. Biofeedback, you can also offer pelvic floor or nerve electrical stimulation, which stimulates muscles, again, and or nerves to increase their strength. Can do bladder training, exercises like freeze and squeeze. So when the urge strikes, they stop and stay still, they squeeze the pelvic floor muscles, they relax the rest of the body, they concentrate on suppressing the urge, wait until the urge subsides, and then walk to the bathroom at a normal pace. Obviously, this is not going to be the first or second or third time they do it, but with continued trial and error, they'll be able to add this to their regimen in terms of treatment options. And also bladder diaries are very, very helpful in terms of eliciting not only these timed and prompted voids as well as their diet and fluid management, but also with regards to assessment of the condition in the first place. So it is an adjunct to history obtained for the from the patient, but it is also an adjunct to treatment. So it can give you information about fluid intake, voiding patterns, urine leakage episodes. Patients are to record in a 24-hour period their timing, their amount of fluid intake, what did they take in, their voids and voided volumes, their leakage episodes, and their activity during leakage. So on the right, you can see examples of abnormal voiding patterns. All right, and then recording a diary, you know, it's very hard to get patients to commit to any type of diary, but usually we'll say 3 to 5 days is generally enough to provide sufficient data to counsel the patients on. All right, medications are an option too. However, keep in mind that a lot of the medications that we are talking about for urge incontinence can also actually contribute. So we talked about anticholinergics being potential reversible cause of incontinence, and you can see it is one of the ones that we also say can be used. So keeping that in mind. Of the types of medications listed, the 2 that are most commonly used right now are the ditropan and detrol, and they're both antispasmodics. They're used to relax smooth muscle. Of note, they're not to be used in patients with narrow angle glaucoma. Side effects are can be seen, such as dry mouth, blurred vision, constipation, impaired cognition, and impaired memory. So obviously, nothing is without risk. Vaginal estrogen has a modest effectiveness. It can help if bladder irritation is an option. One of the other things that we talked about is, and that's coming up, is intravesical injection of basically Botox. It is reserved as a third-line treatment. There are specific protocols that are associated with that, but it is a potential option to kind of decrease the neuromodulation at the detrusor neuromuscular junction. All right, and then surgery for refractory cases are options too, and that could be something like an implantable neurostimulation. Obviously, surgery would be a referral as well. All right, case 2. 85-year-old woman comes in with her daughter. She reports that her mom frequently leaks on the way to the bathroom. She has a history of dementia on Aricept. On her physical exam, she's noted to be frail, walks slowly, uses a walker. Her UA is negative. Her post-void residual is 85. So her diagnosis is urge incontinence. So treatment for her would be to avoid an anticholinergic, which can exacerbate incontinence in patients with dementia. So thinking about a different treatment option. You want to facilitate their functional status. In other words, make sure that they have good mobility devices. And this includes making sure that they have good physical therapy. So if their lower extremities are weak, can we support them and strengthen that again? You want to encourage having a bedside commode so that she doesn't have to rush to the bathroom. And this is definitely the case where prompted voiding is very effective. All right. All right, case 3. So a 67-year-old woman comes in complaining of loss of urine. She is recently widowed and traveling a lot. Her past medical history is negative. For medication, she's basically on oral HRT. Past surgical history is significant for right knee ACL repair. OB history, she had 2 vaginal deliveries, 1 8-pound baby and 1 9.2-pound baby. On physical exam, her BMI is 23. On vaginal exam, she is noted to have vaginal atrophy, as well as a cystocele, as can be seen. Her cough stress test is positive, her UA is negative, and her PVR is negative. On her quid, you can see that she has somewhat of a mixed picture. Her stress incontinence really is quite significant with a score of 9. Her urge incontinence is just barely positive. And a lot of times you can see this mixed type of picture with a patient. All right, so a couple of things of note. Why is her OB history in this case important? Well, we do know that large babies can result in vaginal laxity, and that can contribute. Why does she have vaginal atrophy when she's on oral HRT? And the reason is oral oral HRT, or estrogen therapy in particular, is helpful in terms of systemic side effects, but is not helpful as much with vaginal atrophy, and you actually do need some sort of local treatment and topical treatment in terms of improving atrophy. All right, so what are her options? So diagnosis, we said stress incontinence or even possibly a mixed incontinence picture. Again, first and foremost, we want to start with lifestyle modifications. Other therapies include medications, which are usually less effective and not generally recommended, and then surgery. So what are some of the lifestyle modifications? Again, as we discussed before, diet, fluid management, weight loss, if that's an issue, pelvic floor training and exercise. So about 50% of women have reported being satisfied 1 year after starting pelvic floor muscle training. However, many more will move on to additional modalities. So after a while, it does what it needs to do for a little bit, but then they need more help. Biofeedback, bladder training, bladder diaries, and then pessaries are an option. So what are pessaries? Pessaries are basically these objects that are inserted to control symptoms of SUI by supporting the urethra and increasing urethral resistance. They had been the mainstay of treatment before a lot of the surgical options were placed. They then fell out and not many people were trained in it. And they're starting to get a resurgence as another potential option, again, for stress incontinence, especially with the backlash with regards to the surgeries. And so pessaries are something that primary care doctors can feel comfortable in getting trained and offering for their patients. They come in all different kinds of sizes. For example, the donut pessary, the ring pessary, the Gellhorn, and all of these have different capabilities. Again, they're excellent for control of SUI symptoms during daily activities, but must be removed for intercourse. Results of randomized controlled trials comparing the behavioral therapy with pelvic floor muscle training, incontinence pessaries, and combination therapy shows patient satisfaction 3 months after starting was still higher in the behavioral physical therapy group compared with the pessary group. Patient satisfaction wasn't increased by the combination therapy, but in all groups, satisfaction rates dropped to about 50%. It is a good option for women who want to avoid surgery, aren't very likely to adhere to behavioral physical therapy, and who want more immediate symptom control, then can be provided with behavioral physical therapy. So again, making sure that when we're talking about the behavioral therapy or the physical therapy, this is something where treatment impact should be noted, should be discussed with the patients to occur over time, and it's not an immediate effect. One of the things that has come about with a lot of the focus on women these days is the acknowledgement that urinary incontinence is a large part of poor quality of life for women. And so manufacturers are actually coming out with their own types of quote unquote pessaries that patients can buy over the counter. And so on the right, you can see the Poise Impressa, which is a bladder support. It's meant to be similar like a tampon, and patients can insert them on their own. There's no real good trials in terms of efficacy. They're really for very light stress, urinary incontinence, and especially if there's not much in terms of prolapse. But it is something that women won't necessarily need to come in and get fitted for, whereas the pessaries that were shown above are something that women need to get fitted for. It's not a one size fits all. All right, case 4 is a 68-year-old woman who comes in follow-up for mild to moderate depression elicited at her recent annual exam. Her history is significant. She's been widowed a year, traveling a lot, and has a new partner. Her past medical history is stress urinary incontinence, has been using the pessary, and for the most part, it's been great. If this looks like the same patient, it really is, but she is now 1 year later. So she is coming in with depression. Her quid shows that she still has a little bit of stress incontinence, but her urge incontinence has been, for the most part, improved with her timed voids, as well as with pessary use. So on exam, nothing much has changed. She still has atrophy because she hasn't done any topical treatments. She has her cystocele still present. So what's new? What's different? What's the problem? Well, the patient has a new partner and they've recently become sexually active. She removes the pessary before sex, and sometimes that's a mood killer for her since she realizes sex can't really be spontaneous. Worse, she notes that there is some leakage of urine during the sexual act, which has embarrassed her. Her partner so far has been supportive, but she really can't enjoy intimacy because she's always thinking about the leakage. It's begun to strain the relationship, and patient is despondent now with aging and how the rest of her life is going to be. So one of the things in terms of sexuality in later life is what are some of the causes? And if you look at this list, right there among them is incontinence, and understanding that this is being promoted to patients, and understanding that loss of bladder control is not normal, but it can be treated. All right, so what can we do for this patient? Well, this is where referral and surgery is an option. Surgery at this time is still the best option, is the mid-urethral sling. Now, unfortunately, there's been a lot of pushbacks in terms of this type of procedure because of the litigation surrounding mesh erosion. It is still a great type of procedure. Cure rates are about 80%. And there is large discussions at ways now in which to avoid mesh erosions, and really discuss with patients what are the risks and benefits, and have a really detailed, informed consent with patients. But it still is the mainstay in terms of the best type of surgical procedure. It's relatively quick. It can be even an office procedure in some of the urogyne practices. All right, another type of procedure is the colporrhaphy, which is basically known in the lingo as anterior repair. And what that does is it repairs the vaginal wall and corrects defects in terms of cystocele. So what we do is we'll take this bulging bladder and bulging tissue, which is basically lax tissue. We will remove the outer layer. We will plicate or bring together the inner layer so that there's not as much laxity, and then remove the excess outer layer and then stitch that up. And that can correct and improve prolapse symptoms such as pain, pressure, and SUI, and gives an overall cure rate of 40 to 90%. And this is mostly due, this high range is the reason why it's not considered primary. And it's mostly due to a lot of factors surrounding why the patient needs the surgery, as well as her underlying physiology. Unfortunately, with this, there may be the need for reoperation. A newer modality that is coming out that's being offered in a lot of practices is urethral bulking agents. And these are relatively non-invasive treatments where a bulking agent is injected in under the urethral mucosal layer. So same area that we just treated with surgery, we're going to inject with a bulking agent, and this is to increase outflow resistance. Can be used if surgery has failed, if symptoms recur, in women with symptoms who do not have urethral mobility, or in older women who surgery is not a good option. And again, the cure rate is not so great, 25 to 37%, but it is an option. All right, so now we've come full course. I've given you some patient cases. We've discussed what is the workup and the decision point in terms every step of the way with a elicitation, either the patient complaint or the physician obtaining the information of urinary incontinence. What is the in the yellow is what are the things that can be done in a primary care office? What are the types of urinary incontinence that can be seen? And then when to refer. One of the things that can be promoted to all patients is just bladder health and 13 tips to keep the bladder healthy. And what you can see is this is one of really this, the information that we talk about when we're talking about behavioral modification in the first place: drinking enough fluids, limiting alcohol and caffeine, quitting smoking, avoiding constipation, keeping a healthy weight, exercising regularly, pelvic floor muscle exercises, using the bathroom often and when needed, taking enough time to fully empty the bladder when urinating, being in a relaxed position when urinating, wiping from front to back after using the toilet, urinating after sex, wearing cotton underwear and loose-fitting clothes. All right, so take-home points. Understanding urinary incontinence in the older women and the ramifications of non-treatment on their social, mental, and physical well-being. Remembering to elicit whether or not these complaints are present, if not initially divulged by the patient. It's almost as if you want to assume everyone has incontinence until proven otherwise. You want to also remember when to refer for specialized urodynamic studies and even when to refer for surgical options. Some of my references and then questions. Are you still with me?
Yes, we are. Thank you very much for that excellent presentation, Dr. Sultan. And now if the audience has any questions, if you could please type the question in the chat box and I'll moderate the Q&A session. Just while we're waiting for that, I did have a question about using the vaginal estrogen cream. I know that there have been concerns about systemic absorption being pretty high in patients, almost to the level of taking oral estrogen. Do you have any comments about that?
So absolutely, you can apply topical vaginal estrogen with the thought of increasing it systemically or just locally. And that is basically the art of application. And what do I mean by that? If you're using one of the more common estrogen creams like Premarin, expect that they're going to have systemic absorption. So a lot of times when someone has vaginal atrophy, I'll start them a little bit on Premarin. I'll give them a 21-day course, and it's even then it's not on a daily basis to kind of buff up the vaginal mucosa. And then I'll switch them to a maintenance of a vaginal tablet like Vagifem tablets, or the generic now is the Uvifem tablet. And what that does is it is not as systemic. However, in some older women, especially if they're petite and frail, I still see systemic effects. And with regards to that, once they start reporting things like breast tenderness, you can assume that there is systemic effect and you want to decrease the amount. So it's all in patient report. Again, you want to elicit, you don't want to just start vaginal topical creams without close follow-up with patients and ensuring that they're not getting it systemic. And if they are, that they're not getting it systemic without progesterone opposition if they still have an intact uterus.
Thank you, Dr. Sultan. Any other questions for Dr. Sultan?
I see a question that says, how soon would those symptoms typically develop? I'm not sure. Are we talking about the like breast tenderness and things like that?
Yes.
Okay. So basically, they can be within about a week of using. I'll have patients come back. So anytime I start HRT with patients, I found that if I bring them back in a couple of weeks, they will have already, especially if I'm going for systemic levels, they will already have experienced some of that. And so as early as 2 weeks, they can tell you. And that's why really 3 weeks is my cutoff for topical use of Premarin before switching to either the tablet formation. The ring is another option, or giving them progesterone opposition.
Thank you, Dr. Sultan. Any other questions? While we're waiting for questions to be typed in the chat box, I do want to remind everyone to please follow the links. There's the usual evaluation for today's session, and also there's a special biannual survey that we do that's important for our planning purposes. So please do both the evaluations if you can. Thank you. Okay, I don't see any other questions. So I wanted to thank Dr. Sultan again for an excellent presentation, particularly all the cases that you presented were very useful. So thank you so much, and everyone have a nice afternoon.
Thank you. Thank you for inviting me.
Thank you. Bye-bye.